Thank you for coming today. I'm going to talk about the case of hepatocellular carcinoma with lung metastasis that has been controlled for more than 1 year with cabozantinib introduced as a fifth line of therapy. We have nothing to declare for this study. The case reported here is a 60-year-old man with hepatitis C. He developed HCC E-5 single 30 mm 12 years ago and underwent reduction. Thereafter, HCC repeatedly recurred and was treated with TACE, ablation, and reduction. However, HCC was poorly controlled. And lenvatinib was introduced 4 years ago. After 30 months, it became a progressive disease, PD. Sorafenib was introduced as a second line, but PD occurred after 4 months. Atezolizumab and bevacizumab were introduced as a third line. Pulmonary metastasis achieved partial response (PR), and intrahepatic lesions became stable. 9 months later, he developed ruptured esophageal varices. The intrahepatic lesions became PD, and TACE was performed. Lenvatinib was reintroduced as a fourth line. However, lung metastasis gradually increased, and he became PD after 8 months. The data at that point is as you can see. Hepatobiliary enzyme elevation, thrombocytopenia, and decreased renal function were observed. On the other hand, there was no hepatic encephalopathy and ascites, and the child's Pew classification was grade A with a score of 5. We introduced cabozantinib as the fifth treatment. As a mechanism, cabozantinib suppresses the VEGF pathway and inhibits tyrosine kinase activities such as MET and AXL. The recommended starting dose of cabozantinib is 60 mg per day. However, considering laboratory findings, he started at 20 mg per day. Adverse effects included an increase in grade 1 ALT and AST in CTCAEs. Dose was reduced from 20 mg once daily to 20 mg once every other day because of chronic liver damage, and ALT and AST improved after that. When cabozantinib was introduced as a fifth-line treatment, the lung metastasis shrank and achieved PR, and no new lesions were observed in the liver. And he has been receiving cabozantinib for more than 1 year, effectively controlling the HCC, and there was no increase in tumor markers. Here is a table comparing some clinical data and our case. In our case, by continuing the reduced dose for more than 1 year, good results were shown in both PFS and duration. Tomonari et al. Investigated that no significant differences in PFS between the full dose group and the reduced dose group. In conclusion, cabozantinib suppresses the VEGF pathway and inhibits tyrosine kinase activities such as MET and AXL. Cabozantinib may have a long-term anti-tumor effect. Furthermore, cabozantinib can be administered at a reduced dose to maintain therapeutic efficacy while reducing adverse effects. Thank you for your attention.